Welcome to the Westport Library. Today's program will begin momentarily. Supported by Verso Studios, created locally and shared with the world.
Hi, Westport. Hello, Westport. There we go. Okay, we all woke up. I'm Andrew Wilk. I'm a very proud trustee of our wonderful five-star library here. Raise your hand if you are or were ever a headache sufferer. I would expect that most of you would be because you're here tonight, right? Okay, well, this is a picture of me most of the time. So I have a lot of headaches, and my own neurologist, Dr. Dario Zagar is here with us tonight, joining Bob Altbaum, and we're very lucky to have him, and he's the one that keeps this thing at bay for me. So you've come to the right place if you want to learn more about headaches and migraines and such. You know, in point of fact, 38 million Americans suffer from migraines. I never knew that till I just looked it up. That's 13% of all adults. 1 billion migraine sufferers worldwide. So if you're a headache sufferer like I am, at least you're in good company tonight. Tonight we're going to get a better understanding of headaches, what we can do to prevent them, and when you should worry that a headache represents something more dangerous. We'll be joined by Dr. Zagar, neurologist, as I said, my neurologist, and he's a headache specialist who will discuss the various types of headaches so we can better understand and diagnose them. Before we begin, I want to invite you to join us on November 21st. We think that's a Tuesday. It is a Tuesday. Dr. Michael Fitzpatrick will be discussing the very real fear of dementia. That'll be our final part of this series on the brain. Dr. Altbaum, our host, has received his medical degree from Harvard University, and he completed his training at Mass General and Yale New Haven. Our guest speaker is Dario Zagar, a neurologist focused on diagnosis and treatment of headaches, and Bob will tell you more about Dario's background. So my thanks to both of these esteemed gentlemen, and I'm going to turn it over to Bob and Dario. Thanks.
Thank you all for coming tonight. I'm going to eat the mic. I like to get closer to it. Anyway, I appreciate you all coming to the Westport Library Medical Series that was conceived of by Andrew Wilk and is sponsored by the Westport Library. As he said, my name is Bob Altbaum, and I will be your moderator for the evening. Tonight, we're going to discuss a problem that we all suffer from, a very common problem, headaches. I think I want to discuss some of the common overview of headaches and what makes doctors decide that this might be more serious than an everyday tension headache or migraine. And then Dr. Zagar is going to take a deeper dive into the different aspects of management and what's really new in headache management today. Dr. Zagar was graduated from Columbia University. He received his medical degree from Albert Einstein College of Medicine, did his medical residency at Lenox Hill, and then he did a specialty training back at Columbia in neurology. And if that wasn't enough, he completed a neurophysiology fellowship at Columbia and is certified in headache medicine. I think he knows something about headaches and can help us out. So I'm not going to belabor the statistics because basically it was already gone through, but it's an extremely common problem. We all have headaches. What is a headache? It's a pain in the head that's caused by many different things, but basically there are 50% of all adults in a given year will have a headache that affects their daily activities. And again, as mentioned, 38 million migraine sufferers, 1 billion worldwide. Women, unfortunately, are afflicted more commonly than men, but this is an extremely common headache. These are common types of headaches. We all think of tension. We think migraines, sinus, which really is not as common as people think, lots of different headaches, but every person walking into my office is convinced they have a brain tumor or a subarachnoid bleed. There's just something about headaches. When it's bad enough to get you to a doctor's office, they're extremely frightening, and usually it's not the case. If you actually look at the statistics, you'll find that 48% of people don't have headaches, but 52% of the adults have headaches. The majority have tension headaches, of those headaches, but migraines extremely common, and the number gets smaller and smaller. You're down to 7.4% of other kinds of headaches, which we'll talk about, and only 1% of the headaches totality are going to be something that you're really worried about. So even though 99% of the people think they have something serious, really only 1% do. And that's kind of fortunate. Now, we perceive the headache in the brain, but it's not the brain that really, the substance of the brain that causes the headache. It's structures around the brain or in the actual skull. So in the cranium, you have venous sinuses, those are veins. You have arteries. You have things that surround the brain, that hold the brain, the tissues. That can cause pain in the brain, in the cranium. Outside the brain, there are a lot of structures that are very sensitive, and when they're activated, cause pain. We can imagine the skull, the muscles, eyes, ears, nose, throat. Lots of things can cause pain in the brain or pain in the head, and it could be a headache, but many of them are not due to these structures. There's two types of classifications. The most common classification for headaches is when we break headaches down into primary headaches and secondary headaches. Now, what is a primary headache? A primary headache is due to something almost microscopic neurochemistry that activates structures in the brain and causes a headache. But it's really primary to as a headache. There's no other cause of the headache. So the treatment of a primary headache is to treat the headache and its neurochemistry. If you did an MRI, you'd see nothing. If you did a spinal tap, you'd find nothing. It's really primary to the neurological way we're built, as opposed to secondary headaches, which we all worry about but are less common. A secondary headache is really due to something else. The headache is a manifestation of another disease. So you could have a brain tumor intracranially. This is a list of secondary causes. That's a daunting list. Please don't really stare at it too hard. But it breaks down into intracranial causes. Remember, there are structures in the brain that cause pain. So you could have a stroke, an aneurysm, a blood vessel breaks. You could have a tumor. You could have meningitis. That's an intracranial cause of secondary headaches. Secondary headaches are actually much more commonly due to something much more minor. It could be due to sinuses. It could be due to a dental problem, TMJ, problem with your jaw. It could be that you have sleep apnea and you're retaining certain carbon dioxide, not getting enough oxygen when you're sleeping, and you wake up with a headache. So there are many different causes of headaches. We think about the secondary headaches as intracranial, usually more severe, or extracranial. But the major thing is whether you think about it as a primary headache, which case we're treating the neurochemistry of the headache, or a secondary headache, because in that case, you have to treat the actual cause of the headache, otherwise you don't get the headache better. Treating the pain with giving aspirin or Advil or something temporarily gets them better, but if you have a toothache, you're still gonna have a headache. Now, the primary headaches, these are the three most common, and really only two of them are common. There's migraine headaches, which some of you have. I have headaches, migraines. Tension headaches, which almost everyone gets at some degree, and a thing which is less common, only makes up 1%, and that's a cluster headache. One thing that's very important, when you go looking for a cause, you're not going to find anything. You can do all the tests in the world, but everything might look perfectly normal because it's primary to almost the microscopic neurochemistry of the brain. But they all have distinct features. Migraine headaches are more common in women, so it's got a gender bias. It's often triggered by things like menstruation, certain foods. It's a very distinctive headache in that it has a pulse to it. It's like boom, boom. It's a pounding headache. When people get it, they don't like lights. Frequently, they get nauseated, they vomit. Lasts maybe a few hours to a few days. And that's a very typical kind of migraine. A tension headache is really very different. A tension headache would be kind of like a band. Somebody wrapped a cap around your head. It's just a little too tight. It's usually not as severe. You don't usually mind looking at lights. You don't get nauseous usually. You don't vomit. It can last anywhere from a few hours to a few days. But again, it doesn't have that pounding quality, and it tends to be on both sides, where migraines are frequently, not always, but frequently on one side. And then there's cluster headaches, which some of you, I don't know if any of you have heard of it, unless you've had it, but cluster headaches are really mean headaches. They're usually typically in men. They're one of the few headaches that are primary that can wake you out of a sound sleep. And it's described as people will say somebody's driving an ice pick into my orbit because it's retroorbital. People have committed suicide because of cluster headaches. And the reason they're called cluster headaches is because they come in groups. You can get 6, 10 a day, if you can imagine that. They last anywhere from 15 minutes to 3 hours. They may happen for a few months, and they may go away. Kind of weird. And again, no one knows exactly why. Maybe Dario does, but I don't know why. So, common secondary headaches that are much more common than bizarre things we worry about, the tumors, are things that many people don't think of. Medication overuse headache. You can have somebody who has mild migraines, but they start taking too much analgesics, too much aspirin, too much Advil, too much opiates, and their brain kind of resets. It resets the threshold for pain. The pain threshold goes down, and they start getting headaches very frequently. You can take an episodic headache that happens a few times a month, and you can make it a daily headache just by analgesic overuse. Sleep apnea, I mentioned that before. Some people wake up with morning headaches, and that can be due to sleep apnea. It's not a serious life-threatening disease as long as it's treated, but if you don't treat the sleep apnea, you're never going to get them better. If you don't back off on the medications, you'll never get medication overuse headache better. Things like TMJ, I'm sure you've heard of TMJ, the jaw. People clench their teeth, they bite down when they're sleeping, or they exhaust their jaw muscles and they wake up with a headache. And a very common headache that you see a lot in the hospital, ironically, when people come in because they're 4, 5, 6 cups of coffee a day, they have to have their Java, and then they come into the hospital, they have surgery, they're not eating anything, they're not drinking any caffeine, and a day or so later, they start getting a rather uncomfortable headache, classic caffeine withdrawal headache. The treatment, unfortunately, is to get back to the caffeine, or you wait it out and eventually it fades. But these are common secondary headaches. And the reason that they're secondary, because if you don't figure out what's causing the secondary headache, you won't get the patient better. But they happen to be, as you saw from that pie chart, they're in the minority. So how do we evaluate headaches? Well, the easiest way to evaluate a headache is by listening to the patient. We take a history. Remember, migraines, tension headaches, cluster headaches, they have very characteristic histories. If something doesn't sound like one of them, that's one of the ways you start thinking, maybe this is a secondary headache, maybe this is a serious headache. So the history is important. Obviously, we do a physical exam, and finally, if we're concerned enough, we might start doing labs, which I'll talk about. You don't have to, this is what we do for almost every pain that a person walks into. You know, you want to know where the headache is, when it started, what it's like, what are the associated symptoms you might get with it, like nausea, vomiting, problems with lights. Is there anything about the patient that's worrisome? Do they have any other diseases that might put you on alert? And the thing that's most important is a term at the very bottom, which is red flags. And I want to just go over that in a little depth, because that's really how, in the 15, 20 minutes that I am now graced to see a patient, I have to make the distinction, am I moving on or not with this patient? So again, red flags are things that have a worrisome quality to them, and they really don't fit any of the primary headaches. So one is age over 50. Now, you can get a migraine age over 50, but migraines tend to be a younger person's disease when it starts. Most people with tension headaches, they've already decided this is the way their body's going to react to stress or tension or lack of sleep. That starts in your teens, your 20s, your 30s. When somebody starts with a significant headache after 50 for the first time, you get alerted. And you start thinking about more worrisome things. One of the things you think about, which doesn't even apply to young people, is a disease called temporal arteritis, which is an inflammation of blood vessels, of the big vessels of the aorta and the carotid and the external carotid, and that can cause permanent blindness. So age is an important red flag if it's the first time they've had headaches. A second red flag is systemic symptoms. Migraines don't cause fevers. Tension headaches don't cause night sweats. When somebody comes in with fevers or night sweats or a weight loss that's significant, you don't even have to know that it's a secondary headache, but you know it ain't a primary headache. So by default, it's a secondary headache. That's an alert. That's a red flag. Third red flag is the characteristic of the headache. I think we've all had headaches. We described what a migraine is like, what a cluster headache is like. They have certain relatively distinctive features. But if you have a headache that's just picking up steam, it's getting worse and worse and worse. Or there's a thing called a thunderclap headache, which you don't have to be a doctor to know would be something serious. If somebody says, I just got the worst headache of my life, it just came, my head exploded, in 1 minute I was writhing in pain. That's just not a tension headache. you know it's something serious. That's usually something neurovascular in the brain. You better be very concerned. But it's the quality of the headache, the severity of the headache that alerts you. If a person says, when I bend over, it hurts. Now, that can happen with migraines, but if it's the headache that's almost constant, and yet every time they bend over or cough or sneeze or move their bowels, the headache gets worse, you better go looking for something other than a primary headache. It may not be, but you better, that's an alert that you have to go further. Comorbidities, which is something that I rely on a lot. And when you think about it, you could have a tension headache, you could have a migraine for any reason. But if a person has a history of cancer, and now they're coming in with a new headache, you don't have to be a doctor to say, I wonder if the cancer is spread. That's an alert. If they take a blood thinner because they're on atrial fibrillation, they have atrial fibrillation, and they've had clots, and they're on a blood thinner, and suddenly they're having a new onset headache and they're 63, maybe they had a bleed into their brain. It doesn't have to be catastrophic. It could be subtle. But again, it puts you on alert. An HIV patient or a chemo patient, they're immunologically compromised, and they walk into my office with a new headache. I can't blow that off. That could be an infection. That could be a new lymphoma. That could be something serious. So the nature of the patient is as important as the nature of the headache. You can't blow off a new headache in a person who's somehow compromised. Specific non-neurological signs, I mentioned nausea and vomiting are quite common with migraines. And if they're episodic and it fits the bill, I'm very comfortable. But if somebody's having progressive headaches that aren't classic and episodic, and they're having nausea and vomiting, I start worrying about either increased pressure in the brain, which can cause that, meningitis can cause that, encephalitis can cause that. So you worry about it because it's just not typical. And it certainly is not typical of tension headaches. So these are, again, red flags. And the final red flag, which I think goes without saying, is if a person has a neurological finding or a neurological symptom, other than kind of flittery, kind of scintillating lights, which is typical of migraine, even if it's something else, you really better say, why would a person, tension headaches shouldn't suddenly have arm weakness. They shouldn't have speech problems. They shouldn't have problems with their vision. So you have to think about it. One of the mnemonics we use for stroke applies to neurological symptoms of headache. Be fast, which is balance issues, eye problems, facial droop, arm or leg weakness, or speech problems. You really shouldn't get that with a primary headache. And when you start seeing those, you start worrying about something much more serious. Now, this is the thunderclap headache I mentioned. You don't have to know this, except there's nothing on that list that makes you feel good. So if somebody has an explosion of a headache, you look at that list, you go, oops, I've got a potential, not absolutely, but a potential neurologic catastrophe in my hands. And I will definitely, that person goes to the emergency room, that person's getting CAT scans, they're getting MRIs, they may get spinal taps, lots happen. Another kind of headache that, again, is kind of an alert to me, but not absolute, is a morning headache. Tension headaches, you don't wake up tense, usually. I guess you could wake up with TMJ, but that's a secondary headache due to jaw clenching. But most tension headaches happen as the day goes on. Migraines can occasionally awaken you. Cluster, which is a very infrequent headache, even though it's primary, can awaken you. But you have to think about other causes that are more relevant. And one thing which nobody ever considers, most residents don't consider, a lot of doctors, but when I see a new onset headache that's severe in a woman who's postpartum, just pregnancy, although, God, they've got a kid that's screaming and never stops, they're not sleeping well, their hormones are all fakakta, but reality is they could have something more serious because there are other issues going on. Vascular changes are occurring, tissue changes are occurring, pituitary changes occur, and these are some of the more worrisome things you have to think of in that case. So even a pregnant woman walking with a headache gets my attention. I'm not going to belabor this, but I do want to mention there are certain things that get blamed for headaches that really don't cause headaches commonly. Chronic sinusitis. Now, acute sinusitis can commonly cause headache. You have a fever, you got sweats, you have, unfortunately, your yellow discharge, you feel terrible. But people who walk outside, the pressure's a little bit, the barometric pressure's dropped, it's a little damp day, and they get a headache. And they say, oh man, my sinuses, I'm gonna go take a Sudafed. It works. Well, it works because it's probably gonna run its course. It's often a migraine. And most of those chronic kind of headaches are actually migraine variants. But that's often blamed. Another thing that's commonly blamed is high blood pressure. Again, high blood pressure when it's high, 180 over 110, 170 over 110, That causes some significant headaches. But people who walk around, my blood pressure is 145/85. That's the cause of my headaches. It really is not felt by studies to be a significant cause of headaches, but very frequently blamed. And doctors are just as guilty. On my physical examination, it's very simple. I do your blood pressure, I look in your eyes, your nose, your throat, I feel your temporal arteries, because I mentioned that disease occurs after age 50, temporal arteritis. I check your neck, because a lot of mechanical problems of the neck can cause headaches, and there are things I'm going to talk about that can also be a sign of meningitis. And then I do my neurologic exam. I see how you move your eyes, how you move your arms, your reflexes. I'm looking for something that says there's something else going on in the brain. One of the things I look that most people don't know about, they know that if you can't speak or you can't, but there is a thing that all doctors look at when a person comes with a headache. You look at the eye itself. We always wondered why he's checking with a headache, because the brain has a connection to the optic disc. When I look in, I can see the end of the eye nerve, and if the pressure in the brain is building up, that will affect the disc, and I can see it. So you don't have to be a doctor to realize the one on the left is normal. That's a normal-looking eye. This looks like something bad is going on, doesn't it? I mean, it just looks bad. It almost looks like it's going to burst. You can see it's building up pressure. The nice margins are gone. Everything is looking bad on that eye. You see that? I'm calling Dario. But basically, that's papilledema. Another thing we concern ourselves with in patients with meningitis is just that their neck is stiff. Now, again, you can have a stiff neck and a headache because you have a bad neck. But if the constellation is right, there's a fever, there's a chill, there's a change in the way they're thinking, they're nauseous, they're vomiting, and they got a stiff neck, then I have to go looking for something more serious. So in addition to looking at the eyes, the mouth, the smile, the movement, the walking, there are certain telltale signs that are very characteristic of certain diseases. Again, despite all this, the majority of patients that walk into my office, remember, out of that pie chart, 26% had tension headaches, 14% had migraines, only 7% really had secondary headaches, and only 1% of the total has something dangerous. But we always work backwards. Is it bad? Work backwards. That way you don't make a mistake. And finally, laboratory testing isn't for everybody. Most people that walk into my office, if I get a story that's compatible with a primary headache, and I'm pretty comfortable, I basically will treat the primary headache as a headache. But if I'm not happy, then I'm going to start looking. If they're over 50, I'm going to get a sedimentation rate and a CRP. Those are measures of inflammation, because temporal arteritis that can cause blindness is marked by inflammation, and that's a marker. I may get a Lyme test, although Lyme tests can leave you down a lot of rabbit holes, but I sometimes do. If I'm concerned enough, they're getting an image of their brain. Again, most people walk in and they say, "Doc, I want an MRI." Only a small percentage require one. But if I'm concerned, I'm getting an MRI. If they're getting worse, let's say I don't think it's anything, but 3 weeks later they say it's getting worse or it's not going away, I may get an MRI then, but that's a characteristic of the headache that would worry me. And finally, for that rare patient who I'm concerned about meningitis or encephalitis or something like a subarachnoid hemorrhage, which is a bleed into the substance around the brain, I would do a spinal tap. And when I'm starting to move towards these diseases and these concerns, I'm often picking up the phone and introducing Dr. Dario Zagar.
Okay. Good evening, everyone, and that was great, Bob, actually. Really good summary. See if we can get this to work.
Yes, no, should I get Dave?
I think I got it. Okay. All right, so although I would like to tell you everything you ever wanted to know, I don't have time to do that, but I'll try to give you some interesting tidbits, maybe clear up some misconceptions, tell you some interesting information you might not know. talk about some of the new treatments that we have for migraine. And this is an interesting and important topic for me, not just because I see a lot of patients with migraine, but like Bob and Andrew, and like Cy Sperling, if you can remember, who was not only the president of the Hair Club for Men, but also a member. I am not only a headache doctor, I'm also a headache sufferer. So this is something that has more than just, relevance for on a professional basis. So this was well summarized, but some people ask, how do I know if I have migraine? And there are 3 simple questions that will give you a very good idea. So number 1, do you have nausea? Number 2, has this limited your activities? And number 3, does light bother you when you have a headache? 2 out of 3 of those, 93% chance, and 3 out of 3, 98% chance. So good numbers there. And believe it or not, most people who have a migraine not only never see a doctor for a migraine, but most people don't even have a diagnosis or know that they have migraine. So good start to try to figure this out. And besides the company on the stage here, you can see that this person very likely had a migraine. This is from 9,000 years ago. And you can see the hole in the top of the skull. And that was from a treatment at the time, which is called trepanation, when they used to put a hole in the skull to relieve evil spirits that they felt might cause headache. And I don't think insurance covers that anymore, so we haven't done that in a while. And then some other good company, Thomas Jefferson, Sigmund Freud, Liz Taylor, Serena Williams, may have seen her in commercials, so migraine exceedingly common. And as was alluded to, migraine is much more than a headache. So in a recent study where they, for migraine treatment, where they asked people, what's the most bothersome symptom of your migraine? Less than a quarter said that it was pain with activity. And all the rest said that the most bothersome symptom was actually related to a non-pain issue. The fatigue, the nausea, the mental cloudiness, sensitivity to light, sound, vomiting, mood changes. And this is important to know because people with migraine, I think, often aren't understood by people who don't have migraine, unless they think, migraine, headache, what's the big deal? But it's really not just the pain, it's all the other stuff that goes into it that can be so disabling. Another thing about migraine, this is what we think about down here, is the headache, the pain, the nausea, those other symptoms. But migraine, the headache itself is really only part of what happens for many people in the process of migraine. And it actually starts up here with what's called the prodrome. So a good number of people who have migraine actually have symptoms that start before the headache itself, up to a day in advance. And these can include things like light sensitivity or sound sensitivity, but also some more unusual symptoms, yawning frequently, frequent urination, changes in mood. It can be irritability or kind of a down mood, but it can also be a sort of a euphoric mood. And these things, like I said, can occur a day before the headache starts, and you don't necessarily know what it's from until, oh, I'm feeling it, and then that's what it's from. But when people learn what these are, that may give them a clue of when they're going to get the headache. A certain percentage of people, 20 to 30%, will have what's called an aura, which I'm going to talk about more in a minute. And then another potentially disabling factor is this over here, which is called the postdrome. And so these are symptoms that can occur after the headache itself has gone away with treatment or on its own. And these are symptoms: fatigue, trouble concentrating. People can feel completely drained, washed out, hungover, unable to function. And for some people, these other symptoms are actually worse than the headache itself. And again, something that most people don't really understand, but can really be impactful. So migraine aura, so sometimes known as ocular migraine, but the technical term is migraine aura. And this can either come before a headache or it can occur on its own without a headache. Most common symptoms involve visual distortion, and I'll show you a little image of that. But some people can get numbness or tingling, typically in the face, the mouth, the hands. And some people can have trouble with speech, difficulty speaking. As mentioned, other symptoms can occur, but they're uncommon enough that further workup would be needed. That lasts usually up to half an hour, but it can last longer. So, AI is hot right now. So I said, let's try to work this in here somehow. So I asked Microsoft's new AI generator to show me a picture of what it looks like when someone's having a migraine aura, and that's what they thought. So fortunately, that is not particularly accurate, although it's pretty cool. And then I tried to narrow it down, and I said, okay, what does it look like to someone what would the image be of someone having the aura? So this is a little bit better. Some distortion going on of vision over here, having a headache, not too bad. This is a video that's from actually the Mayo Clinic, not to plug one of a competitor. So this is a pretty good view, and so you can start to see this here. You see those scintillations, the flickering lights on the side, and then loss of vision. So this is compressed into 1 minute of what usually happens over about 20 to 30 minutes. And so usually starts with this barely perceptible little sense that something is off. And most of the time people will pick up their glasses, they'll rub their glasses, they'll rub their eyes, they'll look around the room, see what's going on. And then eventually as it starts to grow, this is happening. So I get migraine with aura, and this is the honest truth. The last aura I had was about 3 weeks ago when Bob called me to ask how my talk was coming so far. So I'm not gonna blame it on him, but it was totally his fault. No, I'm kidding. And fortunately, I did not have a headache that day. So I think this is a pretty good representation of what an aura looks like. It's weird and can be disturbing until you know what it is. Some other misconceptions or questions people have about headache. They say, well, mine's not on one side of the head, or it's not throbbing. Mine aren't nearly as bad as my daughter, my hairdresser, my whatever. I don't have any visual symptoms. No one in my family has them. I started getting them at an older age. I'm a man. None of these things disqualify headaches from being migraine. Bob talked well about why sinus headaches, 90% of people who think they have sinus headaches actually have migraines, and that can be tricky. Next question, the obvious question is, why do I have migraine? So the first answer is blame your parents. So if one of your parents has a migraine, 50% of the child has a 50% chance of having migraine, and if both parents have migraine, 75% chance of the child having it. So with my wife and daughter both having migraine, my daughter is unfortunately out of luck. Now, in terms of why that happens, this is a busy slide, but there's a rare type of migraine over here called familial hemiplegic migraine, where people can actually develop weakness like a stroke during their migraine. And that's caused by a mutation, usually of one particular gene that's passed down. But looking over here, that's not the case for most people with migraine. There's not one identifiable gene that we know of. It's hundreds of different small variants in different genes, most of which we don't know yet, but we're learning more about. So it's a collection of common variants rather than one particular major gene mutation that happens. Also, as Bob was mentioning, in terms of migraine, a lot of the money comes here in this nerve that's called the trigeminal nerve, which controls the sensation from the face, the scalp, the lining around the brain that's called the meninges, the blood vessels. Now, migraine is believed to start typically because of overactivity in a part of the brain called the brainstem, which we'll talk a little more about, which then turns on this trigeminal nerve so that instead of just sensing sensations, it starts to sort of become overly active. It starts to release these chemicals that are pain-producing. It causes inflammation. It dilates blood vessels to the brain. And it used to be thought that that was the main problem, this dilation of blood vessels, which is not, but it plays part of the role. And this trigeminal nerve becomes overly sensitive to sensations, which makes everything become more active. And then parts of the brain become more active, which causes the light sensitivity, sound sensitivity, a symptom called allodynia, where normal sensations become painful. And then this part of the brain back here that's called the occipital cortex controls vision, and that's the part of the brain that starts to become overly active and then kind of depressed in activity with the aura. And then the question is, why does that happen? So people with migraine, we're learning more about this. It's useful to think about the idea of nervous system hypersensitivity. So people with migraine, both in terms of studies, certain brain scans or other electrical tests, but also on a day-to-day basis, have what you might think of as a hypervigilant or hyperexcitable nervous system. On testing, they have lower activation threshold for sensation, meaning it takes less of a stimulation, visual stimulation, auditory stimulation, to activate parts of the brain. Normally, there's a phenomenon called habituation. If someone gets the same stimulation over and over again, the brain reacts less each time, which makes sense. It doesn't make sense to have the same reaction. But people with migraine don't do that. They can have the same reaction even after multiple stimulations. And you can imagine that there might be some evolutionary benefit to this. A person who is more sensitive to sound or to light might be more likely to hear rustling, on the African plain hundreds of thousands of years ago if a tiger was there. But it doesn't serve you so well if you're on a Zoom call or driving on the Merit or something like that at this point. So what was once possibly a benefit has now become maladaptive for people. It's also understood more in this way as a disorder of sensory processing. So besides in a lab, people in day-to-day basis with migraine are more sensitive to sensations. They have lower discomfort thresholds to stimuli. It takes less for a tactile stimulation to be painful, for example, or visual stimulation to be uncomfortable. They have discomfort with patterns, so the migraine sufferers out there are probably very annoyed by that because just these lights and these lines become irritable. They're more sensitive to sound and to odors, and often people with migraine will say that even between attacks, they just are more sensitive to these sorts of sensations. And it's important to understand that a little bit because this has to do with other problems that people with migraine are more prone to get. So people with migraine are 2 to 5 times more likely to have depression or anxiety. Over 50% of people with migraine have anxiety. 4 times more likely to have irritable bowel syndrome, also a disorder of over hypersensitivity of the nervous system. Problems that seem totally unrelated, back pain, generalized pain like fibromyalgia, trouble with sleep, ringing in the ears, motion sickness. And the motion sickness actually is often a childhood trait. So kids with motion sickness grow up to be adults with migraine because they already have markers of this nervous system oversensitivity from a very young age. And this is one of the things that when I see a new patient, I'm often trying to educate them about because more often than not, people with migraine are going to have something else and they have not necessarily put them together. And so helping people who are healthy and young understand why they may have 5 or 6 different problems that are really all kind of manifestations of the same issue can be empowering in a way. So what are the other reasons? So Bob mentioned hormones, women 3 times as likely, and the risk starts at puberty. So before puberty, boys and girls have the same risk. But once puberty hits, it goes through the roof for girls. Migraines are more common in the week before menses, typically because of falling estrogen. And they tend to improve after menopause. Not always, but often, so that's a plus. Stress. So stress plays a role in migraines in a couple of ways. So it's the most commonly reported trigger for individual migraine attacks. And so they can occur either in a period of stress, but also in a period of relaxation after stress, which is sometimes called letdown headaches. So this is the weekend headache, the Friday night headache, the after the meeting headache. So not necessarily while you're stressed, but during that period of relaxation. Another personal story, so when my daughter was 2 months old, my folks came up to watch the baby, and my wife and I had our first break to go to Mohegan Sun for one night of relaxation. And then we get there and we're having dinner, and my wife just starts feeling sick to her stomach and dizzy, and she was having her very first migraine, and that was our staycation. So there's triggers for migraine individually, but then there is how stress can affect migraine in general. So again, we've learned more about how life stresses play a role in migraine. So things that happen early in life, what we call adverse childhood experiences, the more of those people have, the more likely they are to have more frequent and more severe headaches. So these things that occur when we're very young can have this effect. General life stresses and the more that accumulate during life play a big role. And again, not necessarily what you're thinking about. So it's unlike the first thing I mentioned, it's not that you're necessarily feeling stressed and having a migraine, but this accumulation of stress can make people have more migraines. Effects of mood and coping style. So having depression and anxiety increases migraine. Coping style, something called catastrophizing, makes people more likely to have more migraines. Worrying about pain and assuming that this is always going to be the worst makes people feel worse. And then migraine itself causes anxiety, so what's called anticipatory anxiety. When people get migraines that affect their life, and particularly if they don't really know what to do about them, there's an anxiety. When am I going to get the next migraine? Am I going to be able to make plans next week? Am I not going to be able to make plans next week? That can really have a great impact. And so giving people effective tools for treatment often reduces that and thereby improves their headaches in general. Other triggers, changes in environment, things that Bob mentioned, not drinking enough, not eating regularly. People with migraine tend to do best with more frequent snacks and meals and greater hydration. Not sleeping enough, but sleeping too much. Again, another cause of weekend headaches. People oversleep on Saturday morning, wake up with a migraine. Inadequate physical activity. So exercise is like medicine for migraine. They've done studies, they compared randomized people to exercise versus one of the effective migraine medications, and exercise was just as effective. So it's like medicine. People ask a lot about diet, and it's hard to give a lot of specifics. There are certain triggers people can have. Some of the ones people think about are alcohol, MSG, red wine, cheeses. Some people think about chocolate, but interestingly, chocolate's probably not a trigger. It's probably in that little prodrome, one of the things they mentioned was cravings. So it seems like a craving for chocolate may precede migraine. And so it's not that the chocolate is triggering the migraine, it's that you want to have chocolate before you get a migraine, which is kind of interesting. He mentions caffeine, which is that double-edged sword. Nutritional deficiency is not that common, but some people, particularly with things like magnesium and riboflavin, coenzyme Q10, can play a role. Being overweight increases risk for migraine, and so besides just exercise and healthy diet in general, weight loss can be of benefit. And then weather changes. Some people say that they feel like a human barometer just because when pressure drops, they're getting a migraine. Now, when it comes to these triggers, one of the things that's important is that the goal is not to avoid all of these things, but you can't avoid all of these things. It's trying to maximize what you can and understand also that these things are additive. So fix what you can fix, and then the goal is to try to work on other strategies to make the brain more resilient, and that's where things like exercise and relaxation techniques probably also help. So how do we treat migraine? So we're speaking a little bit about lifestyle approaches. Keeping a diary can be helpful, not in perpetuity, but just for a period of time to understand why people are getting migraines. Avoiding some of those triggers to some degree. Relaxation techniques, meditation, other treatments like biofeedback, talking to a therapist, working on stress can be helpful. We talked about managing what makes migraine worse. And then the other two approaches, one is a preventative treatment. We'll talk a little bit about that. And the second is acute or abortive treatment, which is something that you take when you get a migraine to make it go away. So before I get to those, I want to talk a little bit about what, a molecule called calcitonin-related, CGRP, calcitonin gene-related peptide, which is resulted in the biggest revolution in migraine treatment in the last 30 years and has made all people treating migraine very excited in the last few years. So the reason why this molecule CGRP was targeted is that it was found to be involved in the cause of migraine. They found that when someone has a migraine attack, levels of CGRP in the blood go up and afterwards they go down. And people who have very frequent migraines have higher levels of this molecule. And so they found that it's one of the molecules that activates this trigeminal nerve that we were talking about. And then when the trigeminal nerve gets overly active, it releases more CGRP. And so they found that if you can block this molecule, either with something called a monoclonal antibody, which is made in the lab to block this, either the molecule or the receptor, or with certain oral medications, they are phenomenally effective in preventing migraine and quite effective in treating a migraine acutely. So these have been huge. These are some of the medications you may have seen ads for. So the monoclonal antibodies are given by infusion or injection, and those are preventative treatments, usually once a month. And the oral medications are called G-PANTs because of the chemical name. And those are a couple of them that can be used as a preventative. And then there are 2 oral medications and a nasal spray that can be used on an as-needed basis. Now, they're not the right treatment for everyone. And in fact, they're usually not the first treatment that we use for a couple of reasons. One, because of cost, and one, just because they've only been around for several years. And so often older medications are used first. And for some people, maybe better, but they're quite effective, and they tend to have very few side effects. And one of the problems with some of the older preventatives is that they tend to have side effects, particularly people with migraine who have this sensitivity to side effects related to that nervous system sensitivity we were talking about. So these have been really a great addition to the treatment for migraine. So these are some of the abortive treatments that people have been using. So one are non-steroidal medications, Advil, Aleve, don't usually work that well for most people eventually. So triptans are the most commonly used medication. You may have heard of Imitrex, Maxalt. These are oral medications. There's a newer form called ditans, which are like triptans, but don't affect blood vessels, which can be an issue for some people. I mentioned the CGRP inhibitors. There are other medications, some anti-nausea medication, an older medication called dihydroergotamine, DHE, which is what worked for me. And sometimes we use steroids for people in dire straits. Bob wanted me to mention some other non-medication treatment, which is called neuromodulation, which I'll talk about in a moment. So he mentioned medication overuse headache, something to try to avoid, and a reason why most people avoid opioids and butalbital, which were a frequent treatment from the past. So neuromodulation, so these are treatments that have to do with typically electrical stimulation or magnetic stimulation. And you can see down here, this is one called the Cephaly device, and this stimulates a part of the trigeminal nerve. There's another one called Relivion, which stimulates a couple of nerves. There's another electrical stimulation called the gamma core, which stimulates a vagus nerve in the neck. There's this device here called a Neurivio, which actually uses stimulation of the upper arm, which you regulate with your smartphone that can help to abort or prevent a migraine. And then there's another type of treatment called transcranial magnetic stimulation. So these may be an option for people either where the medications don't work, if people don't want to take medications, or as an adjunct to treatment, or situations, someone who's pregnant, for example. But they aren't used as often because they tend to be expensive and not covered by insurance. And the effectiveness is generally not as good as the medications that we have. So they're kind of sexy, but in day-to-day practice, they're not quite as frequently used, but an option for some people. Next is preventative treatment. So I mentioned some of the vitamins that can be helpful, like magnesium or riboflavin. In terms of supplements, there are some herbal supplements. For example, there's one that's called Butterbur that's often my go-to because it can be effective and people generally don't want to take medication. So if you can use non-medication options that work, it can be a great choice. I mentioned some of the lifestyle options. Now, believe it or not, before the CGRPs that I just mentioned, which came out about 5 years ago, there was not a single treatment that was invented specifically to prevent migraines. With 1 billion people around the world, you would think that the drug companies would be salivating to get this, even, besides wanting to help people. But the first treatment just came out 5 years ago. All the treatments we've used previously were medications that were invented for one thing and then found to be useful for migraine, typically in the antidepressant class, anti-seizure medicines, blood pressure medications. We still use them fairly frequently. I mentioned CGRP inhibitors. So people often ask about Botox. Botox is an effective treatment, but it's only for what's called chronic migraine, which is when people have headaches 15 or more days a month. So again, kind of people with more severe and frequent migraine. It doesn't seem to be effective in episodic migraine, but it can work quite well with chronic migraine. I mentioned the electrical stimulation devices and mentioned some behavioral approaches. So this is a very busy slide, but in terms of behavioral approaches, there's an app I'm going to plug that's called Curable that I recommend frequently that uses sort of a mind-body approach with utilizing some of the information that I was mentioning before. And so that's something I recommend to a lot of people who have a lot of the issues that I mentioned: pain, IBS, palpitations, migraines. So again, something that's a great resource for people. So in summary, this is not everything you wanted to know, but hopefully you've learned that it's a common and largely hereditary condition, much more than a headache, and in fact, the pain is often not the worst part. It's related to nervous system hyperexcitability, which can make people more likely to have other issues that can be related. There are modifiable factors that we can work on, including stress, and we have many effective preventative and abortive treatments. So if someone is suffering from migraines, they owe it to themselves to see someone who treats them, because there are so many choices. You don't have to take medications if you don't want to. There are different approaches. And so it's really worth learning more about it and finding someone who likes to treat them. And I think it helps to see someone who's suffered from them. I think when I tell people that I have migraines, my patients' eyes light up and they typically say, "Oh, I'm not happy you have them, but I'm so glad you have them." So more information, these are some good websites, and some of the slides that I used that were not labeled with a study are from the American Migraine Foundation, other ones American Headache Foundation and the Migraine Trust. And then if you want more information about my experience, this is from a podcast that I did for the Curable app, and I don't get any money from them, so I'm not paid to plug this, that you can check out if you're interested. So thank you very much.
I could say all that information give me a headache, but that would be too easy, wouldn't it? So yeah, it's time for your good questions. Our friend John Brandt is over there by our Westport Library step and repeat, as it's called in show.
While we're waiting for the first question, I don't know about you all, but that was a daunting amount of information to absorb. And the thought that this non-student had was, I hope to hell there isn't a pop quiz after this. It would be presumptuous of me to suggest that something was missing from your presentation, but there is another category of headaches that we didn't talk about. Not tonight, honey, I have a headache. First question.
I'm not going there.
Luckily, I do not have headaches or migraines, but I'm very concerned about friends of mine who seem to take an enormous amount of medication. That's scary to me. Literally, I have a friend who comes to my house with a bag of pills. What do you have to say about that?
I would say that it's more common than people think. That there are people that they take their Advil several times a day, every day, or Excedrin several times a day, every day, and it's just been part of their life for so long that they don't realize that that could maybe be causing problems. But it's something that in some cases, the first thing we do is talk about that and say, look, maybe there's a better way that we can address this. And we used to think that the first thing you had to do was get people to stop cold turkey or things weren't going to get better. But there have been some new studies showing that you don't have to do that, actually. And a lot of times people didn't come through the door because they knew the first thing that they were going to say was, you got to stop your Excedrin, and so they just didn't want to go to the doctor and hear it. So utilizing some of these preventative treatments can make people more likely to be able to come off them without being utterly miserable from coming off them. But often getting it done in a gentle way can make a huge difference, and people don't have to be, taking all of that. So it's a good point.
I don't believe I've ever had a headache in my life. Is that unusual, and does that mean I'm less likely to have other neurological issues like a stroke or something like that?
Why did you come?
My wife gets headaches. I wanted to become an expert on the topic, which I have become now.
It is fairly uncommon, but every once in a while I hear people say that friends tell me about their headaches. I have no clue what they're talking about. I've never had a headache, and I don't know what it means. But unfortunately, or fortunately or unfortunately, I don't know, but it doesn't make you any more or less likely to get other neurologic conditions as far as I know. Although I'll say that the one thing, so people who have migraine with aura, for reasons we don't understand very well, have a slightly increased risk of stroke. And it's not that the aura gives you a stroke, it's that something about having this tendency can do that. So that you don't have to worry about, at least that higher risk. But other than that, I don't think it means anything.
That he never had one?
Yeah.
I would say if you ever do get a headache, I would take it very seriously.
That's a good point.
If you had a significant headache, because that would be a big red flag. Over 50, never having headaches, suddenly you have new onset headaches. That's a concern to a doctor.
Good evening. Thank you for being here, and thank you for helping us with this. My question relates to some of the categories of headaches, because the way you describe the different types, whether primaries, secondaries, cluster, migraine, sinus, I don't get a lot of headaches frequently, but they kind of come in phases. So they'll go through a period where I'll get several headaches within a month, and then I won't have them for a while. But it seems like some of my bad headaches fall into 3 of those categories all at once. So, it feels like the way you described a cluster headache, but I also am sensitive to light, or I'm nauseous, which you didn't ascribe to cluster headaches. And I feel like it originates in my sinuses, or there's a single point in my sinuses. So is there an overlap to these, and is it possible to have kind of symptoms that overlap all of these types of headaches?
So it's there is some overlap between some of the symptoms. So for example, people with cluster can have nausea and light sensitivity, although it's usually not the main symptom. People with migraine can have headaches that are behind the eye and stabbing. So statistically, it's likely that you're dealing with migraine. just because migraine is so much more common. If you're having a bad headache, it's probably not a tension headache, right? If you're like, I gotta lie down, that's probably not a tension headache, so probably migraine. Cluster headache, the other thing besides happening frequently in a day, it tends to happen every day or every other day for a period of time, usually weeks to months. So that's, in migraine, it would be uncommon for that to happen. So obviously, can't make a diagnosis, but practically speaking, it's probably migraine.
Hi, my question's about, I've tried everything on there. I've done it all. Nothing was new. Friday, I had the worst headache of my life. I went to the emergency room. Things aren't getting better, they're getting worse. And none of that helps. I'm desperate. Holistic things. This happened to me a while ago when I lived in California as well, and I was in the same kind of cycle of going to the emergency room, and I met a person that is a kinesiologist, and he literally tapped me all over my body, and it took away my headache, and it got me, it did take 8 months of that to get me better, and I don't know why these are occurring again. I don't know. This morning I got a nerve block in the back of my head just to help me and hopefully not have to, as soon as my naratriptans are done, in another couple of days, I'm probably going to be suffering from another headache. So what do you think about holistic approaches? And because I've tried everything on there and nothing works for me.
So a couple things. First off, I'm sorry that you're suffering so much. It's terrible. The second thing is that there's no single thing that works for everyone, and everyone is completely individual. And for some people, things work that we don't understand, or people improve for reasons we don't understand. And I think that this is a situation where trying different treatments is definitely warranted. Because again, for some people doing something, I've had people say, Doc, I took this and it totally went away, this medication that I was started on for something else, or I did this alternative treatment, I had acupuncture, I had something else, and it works incredibly well. So I wish that we could predict ahead of time what's the right treatment for someone, but I think that it's definitely worth trying and thinking out of the box for this. And so I hope that you have some relief. Thank you.
I have a more scientific question. The CGRP, does it pass the blood-brain barrier because of the medication, or is it more outside of the blood-brain barrier?
The treatments, so that's a good question, and it's a little bit controversial, actually. So we'll get in the weeds a little bit for a second. So the monoclonal antibodies are large molecules, and so they don't cross the blood-brain barrier to a great extent. So it's believed that they work more in that trigeminal ganglion that I was mentioning. The oral medications do cross the blood-brain barrier to some degree, but it's still really unclear where they're working. Is it all peripheral? Is there some central? Even with the large molecules, there are some people who think that there may be some central effect. So CGRP is everywhere, and it definitely has, the molecule itself, CGRP, affects the brain and the periphery. And so we don't know completely.
That's because the targeting medication
Oh, right, to get it to cross the blood-brain barrier, yeah, in this case.
Thank you. Thank you. You sort of glossed over the mind-body component of the work that you do.
Yes.
The work of Schubiner and Sarno and all of them. How do you incorporate it into your practice, and how effective do you find it?
So what he's asking about is that there's a whole literature and practice of what you might call mind-body medicine, which really looks at the role of stress in physical health and physical symptoms. That was pioneered by Dr. John Sarno, who started talking about back pain, but other people have incorporated into other fields, including Dr. Howard Schubiner. So I think, and then again, if you listen to my podcast, you'll hear that's something that has benefited me greatly and really helped me with my migraines, as well as various other numerous physical maladies. So I try to utilize those strategies with people. I try to introduce them in a kind of a gentle way, because it's important first and foremost to validate someone's symptoms as being real. And I think that talking about the fact that this is a brain disease, a brain disorder, is important because it is. But I think that when the more we learn about and talk about what's going on in the brain and validating this as a real disorder, I think we've lost something in terms of recognizing how psychological factors can impact how people feel. And so I think that there's a way to do both. And so that's what I hope to do. And I think that for many people, these mind-body approaches are really, really important. And for some people who don't improve with regular treatments, I think they can make a huge difference. And so the Curable app is something that utilizes those strategies. I recommend Sarno's and Schubiner's books. How much they help really depends on how interested someone is and how open they are to the ideas. If you have to meet someone where they are, and if people are not interested in it, if it's not the approach for them, then I don't push, because it's not going to help. But for people where they're like, hey, could this be playing a role? It's something that I think can be very helpful. So thank you for asking.
Anybody else? I think we can go home and take our Advil.
Not too much.
Thanks everybody for, that's right, we're not allowed to take it, right? So please do come back for the third part of this on dementia. As we said in the opening, that'll be Tuesday, November 21st at 7 p.m. And Bob and I are contemplating what our next series will be on. But if you have got some specific ideas, please come and see us, all right? Thanks so much for coming. Get home safely.